Hello, and welcome to our educational video, Lupus and Low Disease State. I'm Annika Hazlitt, a member of the Board of Directors of Kaleidoscope Fighting Lupus, and your host. Complete remission is the goal for anyone living with lupus, at least until we find a cure. However, for many, a better, more achievable goal is something called the Lupus Low Disease Activity State. You may have heard this term when talking to your rheumatologist. But what does it mean to get to a low disease state? How is it different from remission? And how can this difference actually help you better achieve your own treatment goals? Well, in this Q&A, Dr. Don Thomas, clinical rheumatologist and the author of the Lupus Encyclopedia, editions 1 and 2, answers these questions. Dr. Thomas also explains why the definition of remission and low disease state have changed over time, and how these changes have led to improving the lives of people living with lupus. Before we hear from Dr. Thomas, I'd like to thank our presenting sponsor, GSK, for their generous support of not only this presentation, but for KFL's entire Living with Lupus video series. You can find more great lupus resources on GSK's Us in Lupus website by using this QR code. I would also like to thank our community sponsors, Blue Eyed Crow Studio, Tin Rocket, 7 Minute Cinemas, and Due North Studios for their ongoing support. Now, let's hear from Dr. Thomas.
Thank you, Annika, for that very kind introduction. Is your lupus in 100% remission? If not, if you feel like your lupus is active, this video is for you. Achieving low disease activity or remission is incredibly important, and we're going to go over some common questions about lupus remission and lupus disease activity. So a common question is, what is the difference between lupus low disease activity state and remission? Well, first off, when I have a lupus patient, remission is the most important thing. And for me, what that means is that my patient is on hydroxychloroquine or another immunosuppressant or biologic, absolutely no steroids, and has absolutely no active inflammation. If we can't get the patient into remission, because it's not possible in everyone, then low disease activity is the second best result. And so this is the entire reason for today's talk. There are different definitions for these, and they tend to evolve over time. One of the most commonly used one came out from 2016 from the Asia Pacific Collaboration Group. So this is a group of lupus experts in Australia, New Zealand, and a lot of the Asian countries. And what they defined in their study is that they recommended that low disease activity, and they called it LLDAS, which stands for Lupus Low Disease Activity State. That number one, the patient had to have a SLEDAI score of less than 5. And the SLEDAI stands for Systemic Lupus Erythematosus Disease Activity Index, and it's a tool that we use for research purposes that defines how severe someone's lupus is. And it's a point system. The more points someone has for active inflammation, the higher their points, the more severe their disease is at that particular moment. Just some examples: if someone has a significantly low white blood cell count or low platelet count, then that's 2 points. If someone has inflammatory arthritis of 3 or more joints, then that's a 4-pointer. If someone has vasculitis, which is a lot more severe, then that's an 8-point problem. So for a low disease activity, it has to be 4 points or lower. But there's a problem with that, because, for example, one of the 4-pointers is having lupus nephritis, where it's attacking the kidneys with protein in the urine. So let's say someone has even mild lupus nephritis, but they're severely fatigued and they're having a decreased kidney function. That's certainly not low disease activity, is it? So they also said that the physician's global assessment had to be 1 or less. The physician's global assessment is how the physician defines the disease activity on a scale of 0 to 3, where 2 and 3 is moderate and severe. And that's really important because the SLEDAI does not take into account everything. For example, let's say a lupus patient has lupus hepatitis, where their lupus is attacking the liver, or lupus lung inflammation causing interstitial lung disease, and those things are not even counted in the SLEDAI, but the physician knows those are going on, and he can give that patient a 3 and say, no, this patient has severe disease activity. So even though if their SLEDAI was 0, saying they were in remission, because a SLEDAI score of 0 is remission for the SLEDAI, but they're having active hepatitis, the physician global assessment would override that. So a physician global assessment of 1 or less as well. Number 3, they had to be on low doses of steroids, and actually I wouldn't call this low doses, but they say 7.5 milligrams a day or less. And I think that's going to change for most definitions, because since 2016 we've learned that even low doses less than 5 milligrams a day are bad for lupus patients. But that's their definition. The patient had to be on 7.5 milligrams a day or less. They also could not have any additional organ manifestations since the last visit, so that's another important one, and their immunosuppressants had to be stable. Another definition of low disease activity is the Toronto Low Disease Activity Index. This was brought up by a group of lupus experts up in Canada. And the way they define low disease activity is having a SLEDAI score of 2 or less. And so that's more strict than the other definition that we looked at. In addition, the patient could be on 0 steroids, which I like that a lot. And then number 3, the patient could be on no immunosuppressants. Now I think that's way too strict. And I'll just give an example. Let's say that I have a lupus patient, and I have many patients like this, who are just on hydroxychloroquine plus methotrexate and absolutely no inflammation for many years and no side effects whatsoever. Many of my patients are like that. That's a patient who's actually in remission. And so I think that they should be allowed to be on some immunosuppressants if they're working well and not having side effects. And of course, the patient could be on hydroxychloroquine in all of the definitions. So what's the definition of remission? The most commonly accepted definition of remission is by a group called the DORIS. DORIS stands for Definition of Remission in Systemic Lupus, and it's a worldwide group of lupus experts who came together to answer this particular question. So their definition of remission is as follows. Number 1, the SLEDAI score had to be a score of 0, which is remission on the SLEDAI score. But as we talked about before, a patient could be in remission on the SLEDAI score but still have horrible lupus, like if it's attacking the liver or the lung. So they also stated that the physician global assessment had to be 0.5 or less. On the physician global assessment, that's remission or close to remission. Number 3, the patient had to be on low doses of steroids or 5 milligrams a day or less. I completely disagree with that part of the definition. And by the way, the doctors themselves who published this paper, they stated that that was an area of great controversy. A lot of the doctors wanted no steroids, but a lot of the doctors felt that that was just an unachievable result in many patients, and that 5 milligrams a day or less is an adequate goal. And so it ended up becoming into the definition. I think that's going to change, because in the past few years we've learned from research that even doses less than 5 milligrams a day increase the risk of infections and congestive heart failure in our patients. So I think that no steroids is better, but the definition states 5 milligrams a day or less. Other parts of the definition is that they could be on hydroxychloroquine and they had to be on stable doses of immunosuppressants. Now, another very important part of their definition of remission was that they could have positive serologies. Serologies is a fancy word for blood work. And with lupus, we're looking at high anti-double-stranded DNA or low C3 or C4 complement levels, or low CH50, which is a type of complement, or high levels of EC4D, which is another way that we can measure complements. Now, this was also another controversial part of the definition, because some studies have shown that having a high anti-double-stranded DNA and low complements increases the risk of flares and organ damage over the long run. However, there are other studies that show that it was not associated with those particular problems. They went ahead and added this into the definition, saying that they were allowed because of a couple of things. For example, someone can have low C3 and C4 because of their genetics, and they can have absolutely no inflammation from their lupus. And so they wanted to make sure those patients were included in the definition. And then there's anti-double-stranded DNA. Normal, healthy people can have a positive anti-double-stranded DNA due to a false positive or because of the way it was measured. For example, some tests are much better than others. There's one called the ELISA test, for example, that can have a positive anti-double-stranded DNA but not truly represent inflammation. And so they wanted to include those patients in the definition as well. So having positive serology, such as positive anti-double-stranded DNA or low complements, was also allowed. However, I have a different definition for remission. My definition is I want to see no active inflammation whatsoever from lupus. And what I mean by that is no active inflammatory arthritis. For example, I'll use my ultrasound machine and actually look into the joints, and I can see right in the examination room whether my patient has active inflammation or not. Or I want to make sure that they're not having any low white blood cell count, any low platelet count, any active interstitial lung disease whatsoever. And I want to make sure that all of those are gone. Number two, I don't want to see any steroids whatsoever. I want my patients on 0 steroids. And fortunately, today in my clinic, the vast majority of my patients are in remission. Those who are not in remission are in low disease activity and on no steroids whatsoever. If they are on steroids, they're on very low doses. There's 3 reasons for why my patients are doing well, in my opinion, by the way. Number 1 is because we have much better therapies, especially with the addition of biologics. A lot of my patients are on biologics along with their other therapies, and that's helped to get them off of the steroids. Number 2, I use hydroxychloroquine drug levels in my patients. I want to make sure I can use hydroxychloroquine drug levels to make sure that they're taking their medicines, but also I can target a certain level that's been shown to decrease the risk of flares in my patients, and that's a level of 1,000 nanograms per milliliters or greater. And then number 3, I ask all of my patients to abide by the Lupus Secrets. The Lupus Secrets is a list of do's and don'ts that are very important, such as wearing sunscreen religiously, taking your vitamin D religiously, and there's a large group of things. You can easily download them from my website. So a common term you may see these days is treat to target. Treat to target is an interesting concept. Treat to target first came about with rheumatoid arthritis. Before the early 2000s, most rheumatologists unfortunately treated patients with medications to the point where they felt better or that the patient was happy with how they were doing. But the big problem with this is that rheumatoid arthritis experts knew that unless patients got into remission, that they would have ongoing crippling of their joints over time. And so to teach other rheumatologists how to treat rheumatoid arthritis patients better, they came up with something called treat to target, where they came up with an actual definition of how to get patients into remission and told other rheumatologists, you should shoot for this particular target in your patients. When they did that, patients started to do much better worldwide on research studies. And so because of that, in 2014, a group of lupus experts led by Dr. Van Vollenhoven, they published a report called Treat to Target in Systemic Lupus, and that started the path with lupus patients being treated better for their lupus. That definition is changing over time, but the bottom line is that the treat to target is to get patients completely into remission and off steroids. If we can't achieve that goal, then we want to achieve low disease activity with the least amount of steroids as possible. In some studies, you'll see something called remission off treatment. Now, for a lupus patient, I can completely understand that that's what you would love to have. Have to take no medications at all, and your lupus be completely away. However, that's incredibly rare, and that's been shown in multiple research studies. Number one, if someone has systemic lupus or been diagnosed with systemic lupus and they're able to come off of all of their drugs for a long length of time, you have to question whether that patient had lupus in the first place or not. There's a lot of other diseases that can masquerade as lupus. For example, parvovirus infection can cause a rash that looks exactly like lupus, high positive ANA, high positive anti-double-stranded DNA, inflammatory arthritis. They can easily meet the criteria of systemic lupus, and if a doctor did not check them for parvovirus, they could diagnose them with lupus, put them on hydroxychloroquine. They get better, which almost always happens after parvovirus, and then at some point come off of their medicines. Well, it wasn't really lupus. So we have to question whether it's lupus at all. However, there's also different definitions of being in remission off a treatment. In some studies, that means having lupus and being in completely remission with no active inflammation, but also taking hydroxychloroquine, because hydroxychloroquine is by far the safest medicine that we have to treat for lupus. So sometimes we use that as the definition of, in other words, the patient is not on a strong immunosuppressant. Now, it's interesting that the definition of low disease activity and remission are changing over time. And there's multiple reasons for that. Number one, we're having much better therapies coming out regularly. And in the past 5 years, we've had more FDA-approved indications for the treatment of lupus than we've ever had. And we've also recently had studies showing that we have a couple of drugs that are actually disease-modifying agents for lupus patients. And so one thing that's changing is that we're able to get more and more patients into low disease activity and remission. So our definitions are becoming more strict over time because we're having better therapies. Back in the 1990s, most of our patients could not get into remission, and most of them required lots of steroids. And so the definition of remission was very different back then than what it is today. And the same thing with low disease activity as well. In addition, research is showing that some drugs are just not good for our patients. For example, steroids. More recent studies show that even doses less than 5 milligrams a day increase the risk for side effects. And so the definitions of remission and low disease activity are decreasing their recommendations for how much steroids should be used, and those definitions are going to change very soon because of the problem that steroids cause with causing organ damage. So a question that you might have is, what should your expectations be as a lupus patient? You should demand that you try to get into low disease activity or remission. Not every rheumatologist or doctor is a lupus expert. We're having a huge shortage of rheumatologists, so many patients with lupus see a primary care physician who's not a rheumatologist. And so if you're having active inflammation and you know you are, you should ask your doctor, is there anything I can do with my medications, or is there anything I can add to my medications to get my lupus under better control? If you're on even low doses of steroids, let's say 5 milligrams a day, and your doctor can't decrease it because you keep flaring up, again, you want to ask your doctor, could we try adding something to my regimen to see if I can possibly get my lupus under better control so I can get off the steroids? I believe all patients should be proactive in their care regarding this. But there is a very important point. Not all symptoms that you feel may be due to lupus inflammation. We divide symptoms of lupus into two types. There's type 1 symptoms, which are due to active inflammation. Those are the ones where we want to add immunosuppressants or adjust the therapy or increase doses of immunosuppressants. And then there's type 2 symptoms, which are problems that are not due to active inflammation. Those we do not want to use steroids or immunosuppressants because we're just going to give the patient side effects without actually helping them. And I'll describe what those are. An example of type 1 symptoms from lupus would be having horrible joint pain from inflammatory arthritis. I put my ultrasound on the joint and I can see the actual inflammation. I absolutely need to adjust the therapy or add an immunosuppressant or increase the doses to get the patient under better control. But type 2 symptoms are problems that are not due to active inflammation. They could be due to, for example, permanent damage. Let's say someone had horrible lupus arthritis in the past that damaged the joint permanently. They're most likely going to have continued pain in that joint even though they don't have active inflammation. Other patients may have a disorder called fibromyalgia. Unfortunately, fibromyalgia occurs in about 1/3 of our patients who have lupus. It's a problem where the pain nerves of the body are overactive, causing joint pain, difficulty sleeping, fatigue, and immunosuppressants, steroids, they just don't help fibromyalgia problems. Other patients may have pain or fatigue from other problems, such as depression or anxiety. And so unfortunately, all of those things happen more often in our lupus patients. We can have a patient who's in remission with their lupus not having any active inflammation whatsoever, yet feel horrible with horrible fatigue, joint pains because of something else such as fibromyalgia. And so that's a conversation you want to have with your doctor, which is which. Are your symptoms due to active inflammation or something else like fibromyalgia that needs a different treatment? Now, if you're a caregiver of someone who has lupus, which I know many of you watching this are, what is your role as far as remission and low disease activity? You actually have a very important role. And I see this all the time in my patients. I'll have a lupus patient in my office who has their spouse with them, for example. I'll say, "How are you doing?" And they'll say, "Oh, I'm doing great." And then their spouse will say, "Are you kidding? You keep complaining about joint pain and you're just laying on the couch all the time saying that you're fatigued." A lot of times you as the caregiver can see things going on that the patient may be minimizing. And this is a common problem in lupus patients. Too many lupus patients get into the mind frame that they just have to live with the disease. And that doesn't have to be true. And so I encourage you to remind the person in your family or in your circle of loved ones that the kind of things that you're seeing going on with them, write them down, have them address them with the doctor, or go into their office visit with them if they want you to be there or allow you to be there so that you can bring them up. It's very easy to forget what's going on. For example, if you ask me what I did 2 weeks ago, I can't tell you. And I don't have lupus or a major health problem like that. So, but you as the health caregiver can play a vital role in saying, "Hey, wait a second, don't you remember around the time of your menstrual cycle, you felt horrible, your joints were hurting and you were horribly fatigued and your rash got worse." So you can play a very vital role in helping your loved one. Now, unfortunately, not everybody will stay in remission or low disease activity. That brings up an important question. What is the definition of the duration of low disease activity and remission, for example? Well, in the formal definitions, they don't define a particular time. That was an area of great controversy between the doctors who came up with the definitions. I will say, though, that with the SLEDAI score that we mentioned earlier, the Systemic Lupus Erythematosus Disease Activity Index, it takes into account everything that happened within the previous 30 days. And so when we look at the definitions of low disease activity and remission, it does mean over the previous 30 days. So we know that that's going to be a minimum for it. But unfortunately, not everybody will stay in remission or low disease activity. For example, there was a large study done in London where they looked at their patient population and they saw a significant proportion of their patients were in remission by definition. But when they looked at the 10-year mark, most of them had had flares. So flare-ups can happen at any point. And it's very important we get rid of flares, by the way. A study done down in South America by Dr. Urgate Gil and his contemporary peers and colleagues in a group called the Gladel group, they showed that whenever a lupus patient had a severe flare, it increased the risk of permanent organ damage by 2.5 times for every single flare that they had. Not only that, but mild to moderate flares, they had a 50% increased risk of organ damage, permanent organ damage for each of those. So part of the definition of low disease activity state and remission is that whenever a patient goes backwards or has a flare, we still need to adjust the therapy. We need to go up on the doses, we need to add something. Or most commonly, we need to ask the patient, are you taking your medicines regularly? Are you using your sunscreen religiously? Are you taking your vitamin D? Are you staying away from secondhand smoke and things like that? So we got to address all of those for every single flare. We're learning more and more that healthcare disparities is a huge problem. And it's a huge problem in lupus patients. This was illustrated by a study called the Lumina study. Lumina stands for Lupus in Minorities, Nature versus Nurture. And one of the things that they showed, and this was a study, by the way, that looked at patients who have African ancestry or Latino ancestry in the United States and Puerto Rico. And what they showed is that those patient populations had worse disease activity from their lupus and worse outcomes. But they also looked at a lot of different variables to try to figure out why that was happening. One of the things that they showed is that when they looked at the patients who were in remission, one of the big things that played a vital role was insurance. Those patients who had insurance were much more likely to be in remission, much more likely to not have any significant flares compared to those who did not have insurance. This is an important problem. We need to figure out how to get everyone in the United States and every country much better health care. So please advocate with your congressman and the people in government of your local area and your country to try to fight for better health care for everyone, not just people who have the money who can afford insurance. So now that we're coming to the end of the video, I have one strong recommendation. Knowledge is power, and I highly recommend that you be proactive in your health care, because not all doctors are lupus experts, and you may know more than they might know. You should demand that you be in remission. You should demand that you're completely off of steroids. And if you can't get those because if you've already tried a lot of medications or all of them, at least low disease activity. Know what your lab results are. Is your anti-double-stranded DNA level high, which is a sign of active inflammation, possibly? Low complement levels C3 and C4? Are your blood counts low? And ask your doctor, am I having any active inflammation in any of my organ systems, like my joints? Or you can tell if your discoid lupus is active, or if you're losing hair, or if your pericarditis or pleurisy is active, for example. If any of those are going on, then you want to ask for better therapy. Or let's say around your menstrual cycle, you get flare-ups of your joints hurting and your rash being worse. You want better treatment. So ask your doctor, is there anything I can do, such as go up on the dose of my medicine or add something to try to get my lupus under better control? And just be tactful when you ask your doctor these things. And I suspect you'll get much better help with your lupus treatment if you do that. The other thing, lupus is not just about taking medications. There's a lot of other things that you need to do to help your lupus get under better control. I put a list of these do's and don'ts in a list called the Lupus Secrets. Just go to my website, lupusencyclopedia.com, click on Lupus Secrets at the very top. It's a free handout, just print it out and sit down, take a yellow highlighter, highlight everything that you're not doing and try to incorporate all of those into your lifestyle. If you do all of the stuff that I just mentioned, I guarantee that your lupus will be better controlled, you'll feel much better, and your quality of life will be so much better so you can have a wonderful future.
Thank you, Dr. Thomas, for explaining the complex ways in which we continue to try and define success in treating lupus. Once again, a special thanks to our presenting sponsor, GSK, for their generous support of KFL's Living with Lupus educational video series, including this educational video. You can find more great lupus resources on GSK's Us in Lupus website. Just use this QR code. Thanks as well to our community sponsors, Blue Eyed Crow Studio, Tin Rocket, 7 Minute Cinemas, and Due North Studios for their incredible support. And, as always, thank you for watching. We encourage you to visit our website, kaleidoscopefightinglupus.org, and follow our social media platforms for the latest lupus news, program information, award-winning blog articles, and so much more. Thanks for spending time with us. And remember, you're not alone. I'm Annika Hazlitt for Kaleidoscope Fighting Lupus. Please take care.